Good morning, everyone. I was just going to talk a little bit about the Duchenne muscular dystrophy and what our experience are at the hospital that we work. Some of things might be similar to what Mario might have said because we do work quite a lot together. But yeah, and I'll try my best to finish within 20 minutes. So again, just objectives of our presentation is a bit of the role of the physiotherapist and Duchenne muscular dystrophy, assessment, overall management, a bit of the contractors we'll talk about, good and bad exercises, and a bit of mobility. I know it seems quite long, but I try to concise as much as possible. So physiotherapy in Duchenne muscular dystrophy, again, with Marion said, with all the physiotherapy goals, mainly is maximize for useful function, and it's different at each stage and age. That's very important, especially in Duchenne muscular dystrophy, because the condition, the trajectory changes over time. So it's very important that we're targeting the right audience, the right age at the right time, and we're trying to reduce the burden of care and to make things easier, not harder, and trying to add a bit more quality than quantity. So assessment-wise, again, I think Mary noted that and what we do assessment for, and I know most of people understand that, but those are the reasons we will be assessing a child and to be able to target and give the proper treatment that the child needs at that time and age. There we go. And what do we assess? Again, very similar. So we do power, we do joint range, function, and there's the standardized sort of assessment that we do with Duchenne muscular dystrophy, and mobility, gait, and again, as I say, just not walking. There's all about mobility is wheelchair, and mobility is how the child will get around from A to B. So that's all involved in mobility. And we do a few time tests and the 6-minute walk test in research as and when. Yeah, other things that we assess, it's spinal posture, pain, very important to know about pain and how you're going to deal with the pain, because a painful joint or a child that has pain might not comply with exercise that you want them to be doing, or stretch especially. And the falls, and again, falls can happen at school, can happen at home, and how they're dealing at home and school and with personal care. And so all those things that we'll be assessing on every 6 months, or depends on the age of the child. And we're quite lucky that we do have at Great Ormond Street 1 hour and a half to assess each child with Duchenne. So it's quite a long, extensive physiotherapy assessment they go through while they come and see us. And we do a bit of sort of like a OT kind of role, because we do understand a bit of manual handling, and we do this assessment so we can tailor and then pinpoint to where they should go to find a device and help in the community. We do assess their splints and orthotics, although we're not doing it. We have a great orthotic service in our hospital, so they will be able to help and support us with that. Any issues that might come over, and fatigue and the well-being of the child, and sometimes, or most of the times, also the well-being of the parent. And we are quite lucky that where we work, we do have a family therapist dedicated to the neuromuscular conditions, so we can, refer to her if there's any issue with family and the child as well. This is a very confusing slide, and it was done in purpose. So if you think, there was a similar slide in previous presentation, but I find very confusing. And imagine for a parent or a child with the specific Duchenne or any sort of neuromuscular condition. So there is the child, there's the school, there's the occupational therapist, there's a lot of people they need to know and learn from and try to get something to help and support the child. And I think our role as a physiotherapist, I'll try to, although the assessment is quite long, but that's how we're going to target exactly what's needed at a certain age and make sure we are really tailoring or what it will be beneficial at the time and age, because they're not going to remember, the parents of the child are not going to remember everything that was said by each sort of professional, and that's why it can be very confusing. And things that we need to think about when we're doing planning our treatment is contractures and stretches, the weakness and exercise that we'll be doing, mobility and function, what the child is doing or wanting to do, and what can we do to support and help as well. The spinal posture that we do assess every time they come, and again, pain prevention, which there's a few things that we can do about to help and support. Contractors, talking a little bit about them specific, the loss of muscle stretchiness, and then it leads to a tightness of the muscles and as the bone grows. And as we know, normally the bones tend to grow and your muscles take a little longer to catch up. This happens in child with no neuromuscular conditions. And the ones who have neuromuscular condition, that muscle will not grow as fast or maybe never grow. So, and that's where you can get contractors, and then what we're gonna do to help and support that child. Sorry. Again, the contractures is caused by the weakness and tight muscles. And then, I mean, deformity is basically the cause, the inability to achieve normal positions. Again, the contractures can appear at any age and stage, and the assessment will tell us what to target at a certain stage. The hips kind of don't get tight just with loss ambulation, and that's why we assess them every time. Longer finger flexors is something that we really find sometimes very young age, and I think what Marian said, you need to know what you're looking for and how you're looking for to find those tightness to help and support. Again, they can appear in any joints, although there's some sort of patterns of tightness that can occur in TMD, but we will assess most joints. And again, they can appear off on one side or both, and that's when can cause unbalance and cause more problems. And again, this is a good slide because the contractures don't get better by themselves, so we have to intervene and do something about it. There we go. And physiotherapy management, so just moving a little bit, and it has to be what, I mean, as you can probably tell, I'm a pediatric physiotherapist, so it has to be fun. Even for adults, sometimes if it's not fun, people don't want to do things. So it has to be something that will engage everyone, that it's part of the daily life. It's, you know, even at home, helping and support around the house with parents. Some kids might still do it. So it has to be something that will engage everyone and that everyone wants to do. And again, methods of how we actually maintain those muscle strength, and that's how things that we advise on a day-to-day basis with active assisted stretch, self-stretches, I mean passive stretches in brackets, because very rarely we will do that. There's more and more research saying how much passive stretch might not be beneficial. It just can cause pain sometimes. And if you're doing a stretch that's to a child and then they're causing pain, they're probably not going to want you to do that again, and it's just going to cause further problems and probably less compliance to the exercise and the stretches. Splinting we use quite a lot. And serial casting, something that we love doing, is kind of a hands-on, like physiotherapy thing that we do at Great Ormond Street, and we can make as fun as possible. You probably seen slides from Marian, what things and that we can come up with to make things engaging and nice for the child to be able to show off in the house. Well, we have one time a child that came to us and was going to a premiere for the Minions movie or whatever, and then we just made that up, this kind of Minion-looking cast, and then he loved it, and he was, you know, engaged for them and to help and support. You know, there's a problem, but we can make it fun somehow. And then something, when nothing works, then of course there is surgery options. And what do we stretch? Again, as I said, if you don't assess, you don't know what you're going to stretch, and you have to concentrate on things that will cause loss or reduction of function. So again, in Duchenne muscle dystrophy, calf muscles, the finger flexors, brachioradialis, and through your assessment, you'll be able to target exactly what we need at a certain stage. Anything that causes asymmetry, will be targeting it and making sure the child is aware, and the parents as well, of course, what they'll be doing. And anything that affects mobility, ambulation, again, same sort of muscle group, and affect posture of sitting for like ITBs, knees, and hips. And what we not stretch is important to know, to say, because we do work a lot of advice to the community physiotherapists, and then if you're not sure what you're stretching, you might cause more damage than good, and then we never stretch many joints, things that are fixed, because there's no point of it. It's just a waste of time. You could be using your time to do something else by not having to stretch fixed joints. And painful joints, again, if it's painful, stretching it, it's not going to be good, and there'll be less compliance from the child. And the hamstrings as well, we never advise stretching, especially in Duchenne muscular dystrophy. And the reason is we do believe that the hamstrings are there to support and keep and maintain balance with those kids, especially if you think of weakness. Especially with Duchenne muscular dystrophy, they ended up with kind of quads weakness, and then by having your quads weak, they ended up bending slightly their knees in a way, and then cause them to go on their feet. And then we do believe that by having that tight hamstrings, will keep them upright for long, and that's something that we constantly talk about, and then I know that's controversial, but that's something we believe on, and we have good outcomes. And I know that probably a few physiotherapists and therapists here in the room, and we all know a bit of prescribed exercises, but with those cohorts, it's very hard to know exactly how many sets of exercise or how many repetitions. I can't give you that. Again, with force, how much force we can give to a stretch, it's really with experience. As a good therapist, you have to feel the muscle to see if there is any stretch and is there any give. So you make sure your stretching is in line with the muscle pull, and you gotta stretch slowly, and the most important thing, you gotta ask the child to join in with you. Sorry, I keep saying child because of my background, but it's across the board. You have to make sure the patient is in line with what you're doing. They have to, if you're stretching a calf, for example, you have to say, pull your toes towards your nose or something like that. They have to join in. The more they join in, the beneficial will be much better for the child, and it'll be less painful. Because if you, again, I keep emphasizing that, because if you cause them pain when you're doing the stretch, they're probably never going to go like you again, and they're not going to comply with this stretch. And that, unfortunately, the stretch is something they probably need to do for the rest of their life. Again, you saw a few pictures of those, but that's what I was talking about. And we do a lot of zero casting, and we try to make as fun as possible. And we do have a strict protocol that we use for the neuromuscular conditions. And if there's anyone interested in knowing our protocol, just email me, and I'm more than happy to share it with you guys. And so we use a lot of zero casting to help with the management of contractures. AFOs, we try to start at a young age, especially because they will need for a long time and for ages. And so we do have, the AFOs, and those ones that they're called the CCD control device, but we do not recommend them in our clinical setting. I know there's other trusts in the UK, they believe that they are good, and we do not believe that a child should be sitting for 2 hours in a thing that will be stretching them. We want them to be active, we want them to be moving, and we want them to be playing as much as possible, because you can't, if you moving, if you're walking, you are stretching, especially your ankle when you're standing up. So, okay. And again, if contractures are not managed, and then it's fixed, and you might need surgery. So things that we do a lot of feet surgery, like TA releases, and spine, and the good thing about where we work as a physiotherapist, we are very involved from the beginning. So we have clinics with consultants and surgeons that will be able to put our opinion on surgeries, and we will do the rehab afterwards as well. So I think that's very important that they understand what we're thinking, because we do have a more holistic thinking of things, and when we all talk together, we can come up with the best time for those surgeries. Spinal surgery, I'm very much involved with the clinic setting of that as a neuromuscular physiotherapist and a spinal physiotherapist. We do those clinics where I'll be able to help and support what's going to happen after the surgery. Because with the Duchenne patients, they ended up, maybe if they have surgery for the spine, it will be later on in life, and before 18 or whatever that happened. And they, if you think of when they're sitting, they're still able sometimes to feed themselves, but the posture they are in their wheelchair it's kind of slumped, so they can still feed themselves with the hands. But then if you think of putting spinal rods and they're sitting straight, those muscle weakness around their arms, they're not going to be able to feed themselves again. So that's something that I like being part of, to discuss with the parents, because the child, they might love the fact that they can still feed themselves, especially in school, and you might take that away. But there are other ways that you can still manage to do that with adaptations to wheelchair and things, but I think the child and the parents should know this before they go through such invasive surgery. And again, the hamstrings we wouldn't stretch, as I explained before. We believe they used for standing for longer, maybe later on in life when they can't stand anymore and it's causing a lot of problem with sitting, and then that we can consider. And I think what Marion said as well, you've got to really consider that orthosis after any sort of surgery, especially with kids with a neuromuscular condition, because they will probably come back. Again, I will try to talk a little bit about exercises. How much, how often is what I said before. I can't prescribe them. You will be individual to each child and each family. They are all different, and that's through your assessment and subjective assessment that you'll be able to help and tailor this program to the specific child. Again, I think what Marion says, like, play is exercise, so we love them getting out and about and just enjoying themselves as much as possible, and that's what we praise and we really advocate for where we work. And again, we just, whatever they want to do, we're trying to find alternative ways of doing it, and that's how our role as a holistic sort of therapist as well, we're involved in those kind of things as well with those kids. The good exercise, which you probably have taken already, which is symmetrical exercise, concentric exercises, aerobic exercises, and again, I emphasize the word fun there. The good activities, which probably with all the neuromuscular sort of conditions that we talk about, is swimming. We love swimming at any stage, any age, even the younger ones. Horse riding, and I was just discussing earlier, some kids, they might not be able to do horse riding, but they can still, drive a carriage or something, so they still involve in some sort of exercise. Bicycle if they can, and then if not, there's tricycle with the lower gear, which is great. Boxing, martial arts, basketball, anything basically that use both sides of the body. Sorry. And then some of the exercises that we try to reduce and avoid, it's weight exercise, especially with this cohort, rugby, which Mariam spoke a little about before, which is similar. Gymnasts, again, because they do a lot of things on their toes, and we clearly do not want to encourage them to go on their toes, because that's going to happen regardless. And then trampolines, the reasons same, risk of injury and on the toes. Scooters is not symmetrical at all, and we don't advocate for them, and we'll just, yeah, no. And again, running. So just a little bit about mobility. I'll try to be as brief as possible. You have to think about, early development, that not all children crawl, and because mobility is, as I said before, is not just about walking and running and it's about stairs, about trips, it's falls, and there's something they might be struggling with, and what can you do to help and support them at each stage. And the other thing that comes up a lot in our clinics is the fact that some of our kids, they're coming probably 7, 8 years old, and they still in a buggy or a pushchair or a pram, whatever you want to call it, and instead of the wheelchair. So when is the balance? When they should have a wheelchair and not a buggy? We would advocate for wheelchair as soon as possible, because we know they have muscle dystrophy, the degenerative muscle wasting condition, and the spine will play. So the wheelchair, most of the wheelchair, if it's a good provision, they will be tailored to that child. So they will be supportive enough for them to help and prevent any sort of deterioration within the spine. So we would, rather than have a wheelchair, even if it's just to save energy, we use them a lot, because parents, and I understand that being a parent myself, that we want to normalize things as much as possible. And sometimes there are parents that think that having a buggy will normalize a bit more the child, especially when they go into a birthday party or something with the kids. But again, we discuss this a lot with the parents self to come up with the best option. And then, of course, at some point, there's electric wheelchairs. There's something also called the e-motion wheels, which is kind of, it's just got e-assisted wheels for the wheelchair. And that's something that the boys really like to use. And then there's a time then we start the losing of the ambulation. And there are options that we always talk about with our parents. They can stop, because some kids, it's like, oh, I just feel like I'm happy in my wheelchair and I can get around, I can do my thing, everything's sorted. And they don't want to do it. And you have to listen to them. You have to talk to parents and see what the child wants as well. And so you can stop, you can stand, but not do any rehabilitation to do some walking. And again, you can always stand and do rehabilitation in CAFOs, so knee, ankle, foot orthosis. This is a picture of a child in CAFOs. That one's supposed to be a video. I'm not sure if it's going to work, but that basically a child that has got CAFOs on. I'm not sure you can see properly. And we prolonged his ambulation, but more sort of like therapeutic ambulation, not like to walk from A to B, and that's important because we kept the child upright, we kept all the benefits of being standing for and still doing ambulation. So that's something that we use quite a lot with the boys that we want. And I'll try to play the video. I'm just gonna see if it will work. Probably not. No. Anyway, sorry. It's not working, but I'm more than happy to share later on. So just to finalize, and a bit of take-home messages here. Physiotherapy is boring, but we can make it exciting. We can make it fun, as few of the options that I've explained before. Even with the casting that you do, you can put a picture of it that will something that's interested to the child. Again, you got to make part of everyday life. They will understand, the parents understand that you can't keep away from physiotherapy with those conditions. The contractors, they do not get better by themselves, and we always have to sort of intervene. Using splints and position to allow a stretch for the longest possible time. And that's a very important call. And then start young. They will need for a long time, and the more they know, the more they in charge of their own stretches, the more compliant it will be. Swimming, splints, and etc. Yeah, again, my email is just there. I'm more than happy to answer any questions. And if there's anything that's not clear that you want to talk about via email later on, I'm more than happy to receive any message as well. Thank you.
Thank you very much. I think the questions will be later, so thank you. Köszönjük szépen. Kérem.
So, next on is Chiara Mastella, who is a rehabilitation therapist who lives in Milan and has